Hello. Hello. Hello.
ऑफ कर देना सर इसका।
Hello. 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 Check. Check. Hello. Hello. Check. Hello. 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 Check. Check. Hello. Hello. Check. Sound check. Check. Hello. Hello. Check. Hello. 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 Check. Check. Hello. 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 Check. Hello. Hello. Check. Hello. 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 Check. Check. Hello. Hello.
Hello, 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 check, check, hello, 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 check, hello, 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 check, hello, 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 check, check, hello, 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 check,
Hello, hello, check.
Hello, 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 check, check, hello, 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 check, check, hello.
One hour. Hmm. See, from 2 hours I've shortened it to 1 hour.
hello, check, hello.
Hello, hello, hello.
Hello. Hello. Hello. Good morning. मैं शुरू करूं? Good morning, ladies and gentlemen. Let me first introduce myself. I am Dr. Sabharwal, Dr. R.K. Sabharwal. I am a neurologist, a senior neurologist, and with me is my colleague, Dr. Praveen Singh, who is also a child neurologist. We are a team in the Department of Child Neurology and Epilepsy at the Center for Child Health at Sir Gangaram Hospital. Our day is to demonstrate to you the neurological examination as would be done in a child. So we have with us an adolescent who is admitted with a neuromuscular problem, and we will go about to show how we should examine this patient. In the introduction, let me tell you, most of you do get stressed or worried about the subject of neurology. But if you have a good grasp of clinical methods and have a good sense of basic neuroanatomy, it is not that difficult and it is very stimulating. In no branch of is so much of history of medicine written as in the branch of neurology. Starting from Charcot, Babinski, Duchenne, all the great names of medicine are in neurology. And nowhere is history taking more important than in neurology. A good neurologist often makes his diagnosis when the patient walks in, talks to him, and during the period of interview. Can we have the first slide? That is why they say that when you no longer know what headache, heartache, or stomachache means, external functions, electrocardiograms, and X-ray plates, you are slipping. Next. If as a doctor you can't take a good history, and unfortunately you have a patient who's not giving a good history, then you're in the danger of giving and receiving bad treatment. During your interview itself, you can observe a lot of things in the patient. Number one, his attitude, his consciousness. How is he oriented? Is he agitated, restless? Is he focusing? Or is he indifferent to the surroundings? Does he have ptosis, anaphthalamus? Does he have a squint? Is he drooling? Are there equal movements of both limbs? Or is he in a floppy posture, or is he in a stiff posture? Is he in pain? Is he having involuntary movements like tremors, jerks, etc.? At the same time, does he have microcephaly, macrocephaly? Are there any dysmorphic features? Are there any neurocutaneous markers? When he speaks, you will be able to understand, is he dysarthric? First of all, can he comprehend what you are speaking? Is he dysarthric? Does he have paraphasias, etc.? So a lot of things we can infer in just a few minutes of examination. but then that will happen in a child who can converse with you. The examination will have to be modified as per the age of the child. A neonate or an infant or a toddler will merit a different style of examination. So briefly, I'll tell you about this patient and then we will proceed. I came to know about him in just about a day that this patient is a case of acute lymphoblastic leukemia, who had seizures earlier and was on treatment with vincristine, and then he presented with progressive neuromuscular weakness. So now we are going to start off with his examination. I'm not going to discuss this history, but as and when we require any information from him, we will. So, first of all, we should look, if we don't know that he has any disorders, and we have a patient with neuromuscular disorder, we should look for any dysmorphism, head size, ptosis, drooling, any strabismus, any abnormal posture, scoliosis, kyphosis. Does he have pes cavus? Does he have callosities of his hands? Are there thinning of the legs out of proportion to the thighs? See, all these will matter. And are there any neurocutaneous markers? Now, he presently has features of acneiform lesions. These are probably because of steroids, and hair fall because of chemotherapy. Now, his mental status. हमारा नाम क्या है? अभी दिन है कि रात है? अभी इस टाइम आप कौन सी जगह पे हो?
गंगाराम हॉस्पिटल।
कितने दिन से हो?
1 महीना।
अच्छा। 9 और 13 कितने होते हैं?
9 और 13 21।
अच्छा। 12 और 9 कितने हुए?
12 और 9 21।
और 9 और 13?
22।
ठीक है. So if you want to complicate questions, you can do double-digit subtraction. That becomes a little complicated. So 18 में से 9 घटाओ, कितने बचे? 18 में से 9 घटाओ, कितने बचे?
9।
ओके. 23 में से 7 घटाओ, कितने बचे?
15।
Okay. You generally give 5 seconds for a reply. Now for his attention, you ask him to repeat 5 or 6 digits immediately, and a 1 minute to 3 minute recall, you give him 4 objects and ask him to repeat after a minute or 2 minutes, but he should listen or hear those words correctly, and after you मैं आपको 4 चीजें दूंगा याद रखने के लिए. टेबल, खरगोश, सेब और पेन. टेबल, खरगोश, सेब और पेन. मैं बाद में पूछूंगा. ठीक है? अपना उल्टा हाथ दिखाइए. नहीं, उल्टा हाथ कौन सा है? लेफ्ट हैंड. नीचे रखो. सीधे हाथ का अंगूठा दिखाओ. नीचे रखो. दोनों हाथ सिर पे रखो. नीचे रखो. So this tells us about his body parts. Now naming, ये क्या है? इसका कलर क्या है? Red. So he is naming. So we know that his mental status is fairly intact. So we don't need to go into further detail of aphasia testing, etc., because it is very time consuming. मैंने आपको क्या 4 चीजें दी थी याद रखने के लिए?
टेबल, खरगोश,
So he's failed on 2 out of 4. That is not acceptable. So we've done his mental status. mnemonic Dr. Praveen will show you for your rough usage in the exams is adequate. And then speech we have discovered. In speech you have to remember that speech is expressive speech and receptive speech. So expressive speech generally is where we call the Broca's area in frontal convolution, posterior part, and the perisylvian area is the Wernicke's area, where is the receptive speech. So your aphasias may be anterior aphasias or posterior aphasias, fluent or non-fluent. So what you have to check for is what is his spontaneous speech, what is the nature, fluency, articulation, prosody. Then repetition is very important because repetition helps to divide the aphasias tremendously from anterior and posterior. Repetition, then naming, reading, writing. So once you have done this, you will be able to differentiate whether it's Wernicke's, Broca's, conduction aphasias or transcortical, but I don't think that is at your level. Now coming to cranial nerves. The first cranial nerve we know is the olfactory. So how we test for the olfaction is, if you go down the slides, we'll come on to olfaction, is by using any non-noxious substance, but remember that you have to occlude the other nostril. You occlude the other nostril. So even if you use a potent stuff like say alcohol or something, at 10 centimeters he should be able to recognize it. But at home, or if you have barfi or halwa or coffee or even the rind of a lemon, he should be able to identify. Now this is with as far as your olfaction goes. Then we come to visual acuity or the optic nerve, where we test the visual acuity. Now for visual acuity, what you have is, you should be carrying this. This tests your near vision and far vision. Test each eye separately. So you have tested that, then you can do a confrontation perimetry, and आप इशारा करेंगे, ठीक है, कहाँ हिल गई? Now, at the same time, if you're suspecting a hemifield inattention or sensory inattention, you'll be able to do simultaneously when you project both sides. If he's ignoring one side, it could be a hemianopia or it could be a hemi-inattention. So this is how we can test the various fields in a confrontation perimetry. But in a small child, it may be difficult. So what you could probably do is swing something and see if he gets attracted to it from side to side. A fascinating red ball. And then fundoscopy. So after that we come to the third, fourth and sixth cranial nerves. Now when you are looking at the patient, you should be looking at his eyes. So look for ptosis, exophthalmos, enophthalmos, any redness. Look for telangiectasia. Now if he is a neuropathy case, you would definitely be looking for telangiectasia because you would like to exclude ataxia telangiectasia. for any nystagmus. You may have congenital nystagmus, with fixation nystagmus, which you could observe even when you're sitting. And on observation, ptosis, whether it's unilateral, bilateral, strabismus or squint, and exophthalmos. Unilateral, proptosis, redness. So that tells you if there's a retro bulbar mass, or does he have a cavernous sinus problem, does he have scleritis, does he have ataxia telangiectasia. So a lot of information you'll get only for inspection. Now I will just go a little ahead for eye movements. There are two types of eye movements broadly. One are which are under cortical control, like we have upper motor neuron type. These are called conjugate eye movements, in which they, like bulls yoked together, the eyes move in the same direction. So if they look to the left or they look to the right, they're moving in the same direction. Unlike disconjugate movements, which are convergence movements, or accommodation movements, they're going in the opposite axis. So the middle frontal convolution is the area from which the signals are sent, and ultimately they go into the pons, where the parapontine reticular formation is there, the sixth nerve nucleus is there, and they are connected again to the rostral, medial, interstitial, longitudinal fasciculus for all eye movements. So you ask him, बाएं को देखो, दाहिने को देखो, ऊपर देखिए, नीचे देखिए, बीच में देखिए. Or you can bring your finger closer and ask him to. Let him look far ahead, and then suddenly bring your finger. बीच में देखिए, उंगलियों को, मेरी उंगली को देखिए. At the same time, there will be pupillary constriction. Now, then are the pursuit movements. The pursuit movements are occipitoparietal. They are slow movements. They are tracking movements. So, keep your finger in the binocular vision and see that it's tracking smooth. Right? Saccadic movements are very fast. Mainly for rear eye. And then you have the optokinetic nystagmus. Now we look at individual cranial nerves. For that you will have to test each eye individually. So, for example, look like आप सामने देखिए. We bring the middle eye, you adduct it a little. ऊपर देखिए, नीचे देखिए. The erect eye act as elevators and depressors, slight adduction, and the obliques, ऊपर, नीचे. So they do their job in abduction. So this is how we test individual cranial nerves. Now, after the cranial nerves, then we will be testing, before that we would be testing the pupils, the pupillary response. The afferent is to the optic nerve and the efferent is to the third nerve. Now whenever you bring the torch, don't bring it from the eye because he'll be accommodated. You have to bring it from below. Never bring it from the front. So this is how you will test the pupillary response. And you check at the same time that is the other eye also contracting. सामने देखते रहो. See, this is the problem we have in dark-eyed people. Now coming to the fifth nerve, we get the sensory function, all the three divisions, corneal reflex. The corneal reflex also is by the fifth division, the ophthalmic division. In this case, to make the patient look up and outward to the opposite side. उधर देखिए, उधर left को ऊपर. Bring it from the outside and touch the cornea. Make sure you're not touching the head. So get the wisp into a very fine thread. इधर देखिए. So this is an intact blink reflex. And we test his sensations. ये हमने रुई लगाई है, आपको महसूस हुई बराबर दोनों तरफ? ओके. अब आप आंख बंद करेंगे, जब रुई लगेगी आप एक बोलेंगे जोर से जो मेरे को सुनाई दे. आंख बंद करिए. Now, always test homologous areas. One trick, if you are suspecting hysteria, the angle of the jaw, this angle is by C2. So, if this sensation is also lost, and a patient comes to you with a hemisensory loss of the face, and even the C2 is also lost, then something is not something is not working right. You have to keep the possibility that there is a functional disorder going on. Now we test his jaw muscle. When you get the posture in pterygoid, dark the body, then the temporal. See, there is a good feel. Move forward. See the midline. If there is weakness of the pterygoid, the jaw will be pushed to the opposite. So you keep a mental straight line. Now, we come to the side of the basic thing you all know is lower motor neuron paralysis. Because there is a bilateral representation from the upper motor neurons, cortical, from the corticobulbar fibers, the upper part is spared when you have an upper motor neuron lesion. Now, this is interesting. I examined him and I found this just now. Aankh band kariye, this is yours. I can open it without force. Okay. मुंह फुलाइए. मुंह फुलाइए. Not much pressure required. सीटी मारो जोर से. ये होठ ऐसे मुंह फुलाओ, फिर दांत दिखाओ जोर से दांत दिखाइए. See, there is an effacement. You see, दांत दिखाओ जोर से. The nasolabial folds are not so prominent. So he has a bifacial. He has a bifacial. Incidentally, let him perform the full movement, then you try to undo it. Whenever you're testing motor movement, that will be like this. And lastly is the tongue. Open the mouth. Always look for classical regions in the tongue. And the best way is keep the tongue. Look from the side. Look from the side. You'll be able to don't look like this. Look from the left. You'll be able to see. Flexors. Hip flexors and leg extensors test sitting. Knee flexors prone. Abductors in lateral decubitus. Neck flexors in supine, neck extensors in prone position. Facial weakness, again as we described, difficulty to bury your eyes, closure of eyes, whistling, cheeks, etc., etc. Shoulder muscles in the history, difficulty in lifting objects off the shelves now. Tiring easily when combing your hair. These things which the child could do earlier, he no longer can do. Hands can't unscrew a tight bottle. Opening a lock or opening a tight bottle or screwing in a key. So gripping a pen and writing deteriorating. These tells us that small muscles of the hand are affected. Proximal muscles, difficulty in getting up from a sitting position. At the knee, buckling. At the ankle, slipping of slippers, twisting of ankles. So these are small historical facts that can lead you to a diagnosis. So first ask him, whenever you're testing muscles, ask him to perform the action first to see what is the state. You can start from up and go down. This is dono haath upar uthaiye. Now he can lift it up. Now I'm going to test it against resistance.
This is weak. See, I put this at 4 and this at 5 minus. But now let's look at the hands. The hands, there is hyperhidrosis. Whether it's anxiety or whether it's autonomic dysfunction, there is clawing taking place on the left side. So that means the left side is asymmetrically more affected. Because the weakness is more there is clawing taking place There is wasting of the thenar muscles and even the hypothenar. Same here. I see some fasciculatory tremors. These are polymini-myoclonus, fasciculatory tremors. This will happen if the nerve is degenerating or the anterior horn cell is degenerating. You see this very commonly in spinal muscular atrophy or in motor neuron disease. So when you have a whirling Hoffman coming, always use this bright light and look for this. They are very fine, irregular tremors. And if you see this, there is a very good chance that you will be correct when you get the EMG done. So we have wasting, and even the tight. The dorsal interoid, the first dorsal interossei is wasted. So the distal muscles are weak and wasted. Now I'm just going to abbreviate this because since this boy is in case of leukemia and I don't want to fatigue him, I will test one limb just to show you. इस टांग को ऊपर करना है, उस पे जोर नहीं लगाना, ठीक है? थोड़ा सा ये टांग ऊपर उठाएंगे, ऊपर उठाओ, जोर से ऊपर उठाइए. See, grade 3 it is there. और ऊपर उठाइए, फिर तो नीचे मत कर रहे हैं. I'll put it at 4. अब ये टांग सीधी ले जाइए, सीधा नीचे कर, आगे ले जाइए, मत कर. Make sure they don't छोड़ो, अब आगे ले जाओ. This is 4 plus. Sometimes they may lock the knee. I would like to show you his gait. He can't walk independently. Chalo. This is a high steppage gait and most likely due to a foot. Officer. He has to raise his foot because he has to clear his toes from scraping the floor. If it was sensory ataxic gait, it would be gait, it would be high, irregular, but stamping so that he could get the sensations of the floor. Now, important thing that we got so involved in discussing this is how we go about the muscle is inspection to see for symmetry, wasting, fasciculations, any involuntary movements. Then we look for the tone. The resistance that is offered. This is hypotonic. This is hypotonic. This is same thing. This is hypotonia. There is gross distal hypotonia. But otherwise, if he was lying in bed, you would first look at how the feet. In hypotonia, the feet would probably be extended tight with the toes or the feet probably plantar flexed, and rolling them would be stiff. You could feel the resistance in rolling them. Like this, I can easily roll them with one finger. You wouldn't be able to do that. And then flexing. would be tough when you have spasticity or rigidity. And dropping them, this drops like a log. They won't drop so fast. So that is how you will differentiate spasticity from rigidity. And secondly, when you would do the deep tendon jerk, in his case I can't elicit the knee jerk. Now, incidentally, we are seeing wasting over here. Wasting of the EDB, extensor digitorum brevis. This is a very important sign, the EDB. This muscle over here, just anterior to the medial, to the lateral malleolus. This tends to get wasted more in neuropathy than in myopathy. So this is a clue. Now there is wasting over here. Now if you have spasticity and when you do the knee jerk, you will get a shoot. It'll jump up and it will come back and there will be an arrest. It won't go through the normal revolutions. See about 2 or 2.5 in normal people, even who have wrist reflexes. So these are some tricks which can help you to differentiate between spasticity or hypotonia from hypotonia. And of course the hyperextensibility of joints. So tone, power, reflexes. The biceps, look for the biceps tendon once. You don't need to do it 3-4 times. Have the biceps tendon one clip. If you want to do the Jadrasic maneuver to increase the alpha fusimotor drive, pass into place, the jaws also. So for triceps, some people will tell you keep a finger on the triceps to see if it's contracting or not. I don't get any. Same way for supinator, areflexic. And the same I would expect at the ankle, obviously, because in neuropathy, the longest fibers tend to get affected first. So the leg tends to get affected first. And by the time the symptoms and signs reach the knees or slightly above the knees, the symptoms start appearing in the hands. Because it is a length dependent process and the axonal transport gets affected. So after this we would test cerebellar functions. The cerebellar functions, cerebellum is a very, very important part of the nervous system. People just take it as an organ of, not organ I would say, as a system for balance and coordination. No, it has a great importance. Cognition, behavior, and is quite affected in children with attention deficit disorder and autistic spectrum disorders. So, how will we come to know features of cerebellar disorders? Would be, generally they come to you is with ataxia. Ataxia would be ataxia of gait, ataxia of limbs, ataxia of stance, dysarthria, intentional tremors or terminal tremors, nystagmus,
motoric clumsiness. Mild reduction in tone, pendular knee jerks. So the formula used to be vanished. So vertigo is not a strong feature of cerebellum, but what he used to be, proceed down. It used to be ataxia, nystagmus, intentional tremors, slurred speech, hypotonia, E for pendular knee jerks, and D for dysdiadochokinesia. So those were cerebellar features. Since he has motoric weakness, we may get a little amount of pseudoataxia. When you have motor weakness, you may get pseudoataxia. So, you can test the coordination with this, or you can test it with the motor system, the heel knee or finger nose. बाहर से ले जाना है, नाक पे लगाना है, मेरी उंगली पे लगाना है, बाहर से नाक पे लगाओ. See, I think he's fairly accurate for the amount of weakness that he has, left hand side. I expect the left hand to be worse. So, कोई बात नहीं. I will put this as pseudoataxia. So, you've seen the heel knee coordination that is there. See, the idea is that the patient should be like, and it should be done with eyes open and eyes closed. The other way is you can ask him to touch the tips of the toes. He should bring the heel from outside, put the heel onto the knee, then drag it along the shin. Take it out. Make it more complicated. You see how accurate it is. And then is the Romberg sign. Romberg sign is positive in sensory ataxia. So, then we come to testing of sensory system. Now we are coming towards the end. Now the sensory system, we basically have the epicritic, that is the superficial, touch, pain and temperature, and then we have the proprioceptive, which is the deeper structures, the somatic structures, that is position, vibration, deep pressure and pain sensibility. And then we have cortical sensations, which are discriminative sensations, which are high order, which are analyzed, interpreted by the parietal lobe. Basically, all sensations are received by end organs from the skin, subcutaneous tissues, tendons, muscles, etc., transfer through myelinated, unmyelinated, or thinly myelinated fibers, go to the dorsal root ganglia, then to the dorsal column in the spinal cord, where the second order of neurons arises. The posterior columns subserve that subserve the deeper sensations travel in the fasciculus cuneatus and fasciculus gracilis. The fasciculus gracilis is more medial, the fasciculus cuneatus is more lateral. In the posterior column, and they go and ultimately they then decussate and ultimately transfer as the medial lemniscus, go to the ventrolateral posterior thalamic nuclei and reach the parietal lobes, areas 3, 1, 2. Same way the superficial sensations travel ipsilaterally. No, they cross over. They cross over in a segment above or two and travel in the anterolateral columns opposite side. And they also ultimately reach the VPL of the thalamus and to the parietal lobe. So parietal lobe functions are called cortical functions. So what we are going to test are going to be touch. Eyes closed, start from the areas which are affected and then go up. मैं आपको रुई लगाऊंगा, जब आपको महसूस होगी आप एक बोलेंगे. आंख बंद करिए. It is very important to go in this manner because one, you can check up whether there is peripheral neuropathy or not. Second, you can also check up for a radicular distribution, if there is a radiculopathy or not. Now he is perceiving both. I have to find out, is there a difference between the distally or proximally? Because यहाँ पे जितना महसूस हो रहा है और यहाँ पे जितना महसूस हो रहा है बराबर है या कहीं कम महसूस हो रहा है? He is feeling there is a subjective decrease distally. I am going to use this. I don't have that needle. Yeah, I have the needle. I am going to use this, but I would suggest for a sharp object. Nowadays we don't use. We would prefer disposable things, so I think a sharp toothpick would be good for testing. The pinwheel is another way, but with HIV floating around, we get very scared. ये सुई महसूस हो रही है, यहाँ महसूस हो रही है, यहाँ पे और यहाँ पे कुछ फर्क है. यहाँ चुभ रहा है और यहाँ चुभ रहा है, बराबर है. कब चुभ रहा है? कब चुभ रहा है? So this way you can go in the same manner testing. So if you want to test temperature, test tubes will not be enough. You have to have larger sized bowls or containers. People can differentiate between 28 to 32 degrees by even 1 degree temperature difference. So use larger sized bowls if you have to test temperature. But if you find a patient who's got burns on his hands and feet, a little ulcers, and there is wasting in the arms and burns and pyramidal signs in the leg and lower motor neuron signs in the upper arms, always think of syringomyelia. Always think of a intramedullary cervical problem where there is the central canal or there has been a decussation where the pain temperature fibers have been affected. There is a dissociated sensory loss. 128 during fall. कुछ हो रहा है? क्या हो रहा है? वाइब्रेशन हो रही है? हो रही है? So you can feel vibration. You can judge by seeing how long the vibration lasts. Now I am going to test joint position sense.
make sure that you have less, he has less perception of your hand. Sensory system should be done the last because it's time consuming. You require a very attentive patient, and joint position can be taxing. ये आपका अंगूठा है, मैं इसको कभी ऊपर करूंगा कभी नीचे करूंगा. ऐसे नहीं होगा कि एक बारी ऊपर, एक कभी मैं 2 बारी ऊपर कर सकता हूं, कभी 3 बारी नीचे. आपका जवाब होना है ऊपर या नीचे. ये नहीं बोलना बीच में है. पहली पोजीशन के हिसाब से ऊपर है या नीचे है. ठीक है? अभी कहां है? अभी 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 अभी. See, he's given me all correct. So, we are getting his posterior columns good. Now, one thing, because he was sitting, I couldn't do his superficial reflexes. This is for you as exam going students. The gymnastic, you know, L1, to be done only in gents, in males. But when you are doing abdominals, remember one thing, don't go from inside outside. Go from outside inside. Got it? The purpose of your sensory examination is to determine what fibers are affected. Is it a small fiber or a large fiber? Neuropathy or is it radiculopathy? Is it a mononeuropathy or is it a mononeuropathy multiplex? Is there a sensory level to tell you whether it's spinal or cranial nerves involved or not? Because all these help to tell you whether to restrict your differential diagnosis. Always ask for autonomic symptoms. Sweating, constipation, salivation, and bladder disturbances. Spine, skull should all be looked forward. Then lastly, meningeal signs. So basically, I think have we missed out anything? Cortical sensory, okay, this will be the last thing. Number one, to test cortical sensory loss, you first of all, the sensations must be intact. Shape, size, structure. By giving something in his hand, he is going to decipher what it is. आँख बंद करो. तुमने देखा मैंने क्या डाला है? देखा चीटिंग किया है. You know what it is. अब हम कुछ डालेंगे तुम्हारे हाथ में. ये क्या है? आँख बंद रखना. Let him get the whole feel. You rub it around his hand. ये क्या है? पता चल रहा है? बोलो. square जैसा है. Anyway, it's a pen drive sort of a thing. You won't know. Okay. आँख बंद करो. आँख बंद करो. ये क्या है? ठीक है. गोल चीज क्या गोल चीज है? उसको घुमाओ अपने हाथ में. I think he's not been able to move it around. ये आलू है, गोल चीज. बैंगन है, पैसा है. Then is graphesthesia. You write something on his hand. See, he's got sensory loss. This thing. It should be more than 4 centimeters. आप बंद करिए. आपके हाथ में कुछ लिख रहे हैं. आप बताना. क्या लिखा है? हैं? नहीं, देखो मैं 1, 2, 3, 4, 10 तक लिखूंगा. कोई भी एक लिख सकता हूं. ठीक है? Good. So at the same time you can then test paragnosia. Give him 2 objects, one after the other, check which is heavier, which is lighter. 2-point discrimination, sensory inattention. These are all things which you sensory loss. Look for neurocutaneous markers, cafe au lait spots, shagreen patches, subungual fibromas, adenoma sebaceum, tuft of hair in the skin, sacral dimple. So all these sort of things you have to look for. Any ulcers, we've spoken of. Then dysmorphic features, abnormal dermatoglyphics, clinodectomy, if he's got any hypertiroidism, mouth, things wrong with toes, scoliosis, kyphosis, all these thickened nerves are important. So in brief, what I've tried to tell you or teach you today is an attempt at a neurological examination. This is not all in all that I could do, but the attempt has been to stimulate you to understand how it is done. And I think if you read and perform this routine in your patients, say 1 patient every day, you should be able to manage with the knowledge of your neuroanatomy to do well in neurology. So this patient we feel has got Wittgenstein-induced neuropathy, which is a peripheral neuropathy, predominantly probably small fiber predominant, and also has associated cranial nerve palsies at present. Thank you very much for your attention. Thank you very much. या तुमने बहुत मेहनत की हमारे साथ. तो टॉफी मार ली तुमने? ले ले एक टॉफी. मिसेस थैंक यू वेरी मच. हमने आपको बहुत
Hello, hello.